خب با عرض سلام و احترام مجدد برای تمام همکارا هم از هلند و هم از افغانستان، بازم به پروگرام سیوم ما خوش آمدید. قراره که همه شما دوستان پیش از وقت ایمیل را دیدید و تمام لکچرها برای شما روان شد. مطلب امروزی ما درباره تشخیص کووید 19 می باشه و در پروگرام امروزی ما هم متخصصای خود از هلند با خود داریم و پروگرام امروزی از بخش 6 یا متخصص رعیت جناب هاشمی صاحب با خود داریم که در شفاخانه اکادمیک امستردام به صفت متخصص وظیفه اجرا میکنن و در بخش داخله همکار ما دکتر صاحب اوریاخیل هستند، ترینر متخصص بخش داخله، و در بخش رادیولوژی همکار ما دو متخصص همراه خود داریم. متخصص صلاح، ترینر متخصص رادیولوژی هستند از شفاخانه اکادمی نایمیخان، یکی از شفاخانه‌های اکادمی هلند، و همچنان متخصص مرسل رحیم صمیم با خود داریم که در یکی از شفاخانه‌های اکادمی هلند حالت تخصص رادیولوژی خود هستند. در اول پروگرام البته که لکچر به زبان انگلیسی است، قسمی که ما در دعوتنامه نوشته بودیم، و در آخر پروگرام موقع سوال جواب است. میتونین که به زبان دری یا پشتو سوالتان از متخصصین داشته باشین. امکان داره که جوابتان به زبان دری باشه، چرا که همه دوستا به زبان پشتو آشنایی ندارن. متخصص صاحب هاشمی، شما میتونین که لکچرتان آغاز کنین. بفرمایید.
بله، تشکر دکتر صاحب کوهستانی. سپاس فراوان از حضور همکاران گرامی ما در افغانستان. It's my pleasure to present you this week's webinar on how to diagnose COVID-19. As mentioned, my name is Syed Mohammed Shah Hashemi, and I'm a pulmonologist at Amsterdam University Medical Center, location VU University Medical Center, and my co-authors are Dr. Salah, Dr. Oriakhil, and Dr. Samim, as mentioned. So this is my disclosure and the short disclaimer. I have already mentioned the program, so we move to slide number 5, which is a short presentation of a case. It's about a 70 years old obese male with a BMI of 31. He uses ACE inhibitors for cardiovascular events in the past, and he came to the ER because of fever, shortness of breath, and fast breathing. He also needed 5 liters per minute of supplemental oxygen to maintain peripheral saturation of 94%, and we noticed by basilar crackles. So this is a kind of case we all are familiar with, and we have a regular differential for it. But in light of present pandemic and the incidence of COVID-19, this patient could, of course, have COVID-19 disease too. Furthermore, this short presentation shows some important features of COVID-19. For example, if we move to next slide, number 6, first, the clinical presentation is not specific. This patient can, of course, have COVID-19 disease, but he can also have other viral or non-viral disorders. Second, there are certain risk factors for development of severe or even fatal COVID-19. I will touch on this point in the coming few minutes. Moving to slide number 7, as you can see, asymptomatic infection have been well documented, but we don't know how frequent it is. The asymptomatic patients may have objective abnormalities, for example, abnormal CT scans in up to 50% of cases. This CT scan, which is shown here, is a real example. As you can see, there are extensive bilateral sharply demarcated, mainly subpleural ground glass opacities, which is highly suggestive of COVID-19 disease in the time of epidemic. But the patient was completely asymptomatic and all the abnormalities disappeared after 6 weeks. So moving to slide number 8. When symptomatic, it ranges from mild to critical. For example, a publication from China, which included more than 40,000 patients, mild cases occurred in about 80% of patients. Severe cases defined by presence of hypoxia, involvement of more than 50% of the lungs, and dyspnea was about 40%. The critical cases was about 5%, for example, with respiratory failure, multi-organ dysfunction, or shock. The overall case fatality rate in this publication was about 2.3% in China. The case fatality rate means the number of reported deaths divided by the number of reported infections. That's the positive tests. For global, it's about 7%, which has been reported by WHO recently. More importantly, the infection fatality rate, defined as the number of deaths divided by the number of all infections, regardless of symptomatic, regardless of tested or not. It's about 0.85%. It's very difficult to calculate this rate, of course, but the outbreak in a cruise ship gave the scientists a unique opportunity to follow up all these passengers in time and to calculate the rate, which is about 0.85%. When we are interpreting these data, the case fatality rate, we should be very careful because of the differences in test policy, in demography, in the level and availability of healthcare in different geographical regions. So moving to next slide, I think number 9. You have clearly the impact of age. If you look at the top diagram, showing the age distribution of the patient in China on the left, and on the right, you can see the impact of age on case fatality rate. The bottom of the slide shows nicely the impact of comorbidities, as the orange plot at the bottom shows the patients without comorbidity, and the blue and the green plots show one or more comorbidities in relation with the cumulative endpoint, which consisted of admission to ICU, initiation of mechanical ventilation, or death. We continue to slide number 10. Here you can see the impact of age on case fatality rate in Italy and in China. As you can see, advanced age is associated with considerable more fatality. Please note the overall case fatality in Italy, which is 7.2, compared with the reported case fatality of China, which is 2.3%. Moving to next slide, number 11. So severe illness can occur in otherwise healthy individuals at any age, but again, it mainly occurs in advanced age and in patients with underlying medical comorbidities. The next slide lists the other risk factors for severe COVID-19 disease. So besides age of above 65 years, the cardiovascular disease, hypertension, diabetes mellitus, chronic lung disease, for example, COPD, cancer, particularly hematological cancers or lung cancer, chronic kidney disease, obesity, the MAFLD, metabolic associated fatty liver disease, smoking, they're all associated with high associated with severe disease. Although the data are limited to support, but some authorities consider immunocompromising condition in liver disease also as possible risk factors. And please note, males have disproportionately high number of deaths compared with females. The next slide shows some lab features which are associated with severe COVID, and they include elevation in D-dimer, C-reactive protein, LDH, troponin, ferritin, and CK, and also decrease in the absolute number of lymphocytes. The next slide, we continue. So they are the symptoms that may be associated, may be seen in patients with COVID-19. And they could be included fever, cough, dyspnea, anosmia, ageusia, sore throat, myalgia, chill, rigors, headache, rhinorrhea, nausea, vomiting, diarrhea, fatigue, confusion, or chest pain. The first part of the list are frequently encountered symptoms, and the lower part of the list are the symptoms which occur less frequently. Moving to the next slide, number 15. So the pneumonia appears to be the most serious initial manifestation of the disease, which associated most of the time with bilateral abnormalities on chest imaging. Slide number 16 shows a nice proposed classification of the disease, as at the beginning of the disease, it's mainly viral response phase with associated symptoms which are listed below. And at the later time, it's mostly host inflammatory response phase with associated symptoms. And at the middle, you see some overlap of both phases. Next slide. The laboratory findings which may be encountered in patients with COVID-19 are lymphopenia, elevated aminotransferase levels, elevated LDH, elevated inflammatory markers, and elevated D-dimer. Next slide. Slide number 18 is about microbiological test, a very important subject. The frequently used tests are the nucleic acid amplification tests, are the NAAT, to detect the virus RNA. For example, there are many various tests for it. For example, a real-time reverse transcription PCR. The common gene targets which are included in various tests are the N, the E, the S, R, the RP gene targets, which will be copied, amplified, and detected by the test. Next slide, I think number 19. Continues on microbiological test and AAT. So the diagnosis of COVID-19 disease is made by detection of SARS-CoV-2 RNA by one of these tests, usually the RT-PCR. There are various RT-PCR assays are used, and the accuracy and the predictive values of these tests have not been systematically evaluated. If you look at the sensitivity, they are likely to depend on the precise assay, the type of specimen collected, the quality of a specimen collected, and the duration of illness at the time of the test. Next slide. Number 20, I think. So the specificity of these assays are very high, reaching about 98%. And the specimens from the lower respiratory tract may have higher sensitivity. For example, in a publication of 205 patients, it seemed that bronchoalveolar lavage had a sensitivity of 95%, followed by sputum with a sensitivity of 72%, and the oropharyngeal swab showed a specificity of about 32%. Next slide, slide number 21. So you have to follow the local guidelines for accurate testing and interpretation because of availability of various tests and because of the test policy. Please note that specimen collection, handling, and transportation is very important and should be according to validated protocols. For example, during the transportation, the swab should be maintained in the temperature of 2 to 8 degrees of centigrade. Slide number 22. You can watch a video how to correctly collect the specimens from nasopharyngeal area as you advance a swab into the nasal cavity horizontally until you reach the nasopharynx. You can watch the video yourself, of course. The next slide shows about the positivity and the false negativity of the test. As you can see, the peak of the test is when the patient is symptomatic. It's probably the peak should be shifted a bit to left, as most of the patients show positive RT-PCR at the beginning of the symptomatic disease. But if you test the patient very early or very late in the course of the sickness, it's maybe false negative. Moving to the next slide. There are other tests which are routinely not performed. For example, serologic tests to identify prior infection. They are not validated yet. Viral sequencing is important to detect any mutation or changes in the structure of the virus, but it's not for patient care. And the rapid antigen and antibody tests are not yet recommended because of lack of validation of these tests. The next slide. If you consider or suspect some other pathogens beside COVID-19, it's reasonable to test for other viral or bacterial infections if it has implication on the management of the patient. But please note that the detection of another pathogen does not necessarily rule out SARS-CoV-2 virus co-infection. There are several reports of co-infections. So we continue on our case, but the next slide, it should be slide 26. So the patient was admitted and the RT-PCR test came positive. The patient deteriorated on day 5 after admission and had to admitted at the ICU, and mechanical ventilation was initiated. And thereafter, the CT of the chest with pulmonary arterial phase showed large pulmonary embolism. So this emphasizes the importance of some common complications that could occur during this sickness. So beware of common complications, and when you suspect a complication, you have to do, of course, proper diagnostics to detect the specific complications. So we move to slide number 28. The complications which can occur are listed here. The ARDS, the venous thromboembolism, including pulmonary embolism or stroke. Many cardiovascular complications can occur, for example, cardiomyopathy, myocarditis, arrhythmias. Furthermore, acute kidney injury, acute liver injury, many neurologic complications, for example, confusion, cytokine release syndrome, secondary infections, sepsis, and, for example, aspergillosis in ICU patients and DIC. So that's the end of our first part of presentation. We continue with the second part, which will be presented by Dr. Salah. Thank you very much for your attention.
دکتر صاحب پرویز جان مایکت خاموش است. حواستان نمه.
دکتر خیبر سلا باید آغاز کنیم.
دکتر صاحب خیبر سلا مایکشان چالان است؟
بله. فکر کنم مصروف عزیزتن که یعنی تو امو پریزنتیشن
بله
ما شریک کنیم.
سوالی که از دکتر صاحب هاشمی دارین فقط نوشته کنین و انشالله به نوبت در آخر پروگرام موقع سوال جواب و دیسکشن هم هست، باز دوباره درباره‌اش بحث میکنیم. دکتر صاحب صلاح معذرت میخوایم. صدای ما را دارین؟ جان رزما جان صدای مرا میشنوی؟
بله من میشنوم. افهم دکتر
مایک خیبر جان باز است؟
بله. از چی رفتن؟ از نیستن؟
باش ما برشان زنگ میزنم.
نه هست دکتر صاحب خیبر هستم تا مایکش میبینم بسته است.
مگر من روشن کردم هم
دکتر جان مایکت بسته است فکر کنم.
از مجان شما سعی کنید.
زی جان در کجا میبینیم؟ من هیچ دکتر خیبر
ما نایفم
سوال درست شد. فقط مایک تک چالان کنی میتونی صحبت کنی.
نفر چهارم است از جمع حساب ما.
میبینم.
این درش.
کلاگی میتونه خواستن میکروفون روشن کنن یا نه اگر
some technical issues فقط اونا دوباره آنلاین میشن. میتونیم تا وقتی که دکتر صاحب سلام میاین سوالای دوستا را داشته باشیم. اگر کسی سوال از متخصص هاشمی داشته باشن میتونن که مایکشان باشه و بتونن سوال خود عرض کنن.
اگر کس سوال داشت اینجا پایین نوشته کنن باز من میتونم که میکروفونشان روشن کنم.
دکتر صاحب سلام همراه ما می باشن چند دقیقه بعد فقط دوباره پس اینترنتشان وصل میشه. اگر در خلای وقت کس سوال داشته باشن میتونن که سوال خود.
بله بشنوین. سلام.
بله خدا معرفی کنید شما.
دکتر مجیب الله
صدایتان نداریم با خود دکتر صاحب محبوب، صدایتان نمیآید. دکتر صاحب عزیزم میتونین سوالتان رو بکنین. رسم جان بله
صدای منو میشنوین؟
بله بفرمایید دکتر صاحب بفرمایید.
فقط از شما عیزا زرمیر هستم، استاد دانشگاه. سوال من از دکتر سیبی بود که علت مرگ میره پایین در پیش اطفال چی است؟ اتو گفته میشه که به خاطر از این است که چون اطفال در ریسک انتقالات در دوران طفولیت زیاد هستند، به او خاطر آنتیبادی ها قبل ساخته میشه، به او خاطر ریسک مرگ میره پیش اطفال پایان است. آیا کدام دلیل دیگه به این وجود داره استاد محترم؟
تشکر. دکتر صاحب هاشمی گرفتین سوالشانه؟
بله تا جایی که من اطلاع دارم علت اصلی مسئله روشن نیست. میفهمین که پاتوژنز کووید 19 بیشتر روی سایتوکین ریلیز است. احتمال داره که در بین اطفال اینفلامیشن ایجاد شدن در شخصای از اینا کمتر باشه. تا جایی که من اطلاع دارم در این مورد.
تشکر.
ای که آنتیبادی ها در این مورد سهم فعال دارن، من چیزی در مورد نخوندم.
تشکر.
استاد اجازه است یک سوال خواستم داشته باشم؟
بفرمایید.
استاد محترم آنتیبادی در کدام روز به اوج میرسه؟ مثلا ما تا چی زمان گفته میتونیم که مریض میگن که بعضی مریضا در صورتی که اگر به های ریسک یعنی بسیار شدید مریضی کووید 19 استفاده کنه دوباره مصاب نمیشه. در افغانستان یک چیز گفته شده رئیس بین دکترها و در صورتی که اگر بسیار ضعیف استفاده کنه مریض میگه دوباره مصاب میشه به خاطر از اینکه میگه پیک آنتیبادی ها بلند میره، به اون خاطر دلیلش همین است. حالا این مسئله درست است یا اشتباه است و پیک آنتیبادی تا در روز چندم بعد از زمیش میرسه در سایر مسئله؟
سوالشان نگرفتین متخصص؟
اطلاعات در این مورد هم کافی هنوز وجود نداره. در هفته‌های بعد از شروع سیمتوم در مرحله اول IgM و در مرحله دوم IgG آنتیبادی ها ایجاد میشن. شواهدی وجود داره، درست از شما همونطور که میفرمایید دکتر صاحب، شواهدی وجود داره که کسانی که مریضی سخت سپری میکنن مقدار تیتر آنتیبادیشون زیادتر است و اونایی که مریضیشون کمتر شدید هست تیتر آنتیبادیشون کمتر است. ولی که تاثیر تیتر آنتیبادی در ری انفکشن چی هست و آیا ری انفکشن واقعا وجود داره یا نه، و آنتیبادی ها تا چی مدت پروتکتیو هستن، در این مورد هنوز اطلاعات کافی وجود نداره. جواب قطعی متاسفانه کسی دادن نمیتونه در این مورد.
خیلی ممنونتون دکتر صاحب، تشکر.
شما آماده هستین دکتر صاحب سلام؟
بله صدای من میاد؟
بله صدایتان میاد، بفرمایید.
خوب. Okay, I'm sorry for the technical difficulties, but I'm online now, so we will give you a brief introduction to the chest imaging, and my colleagues, Dr. Hashmi, Dr. Orakhel, and Dr. Samim also work with me together. We put this presentation for you. If there are any questions, you can ask it at the end of the presentation. So I have nothing to disclose. So the role of chest imaging in the measurement of patients during COVID-19 pandemic. To start with some background information, as we know, on 11th of March this year, the World Health Organization officially characterized the spread of COVID-19 as a pandemic. And the goal of the public health changed very drastically from containment to mitigation to actually reduce the incidence and morbidity and mortality of COVID-19. So this made it necessary for all to move to an early diagnosis of COVID-19, which makes it very crucial for the disease treatment and the control of containment. So as we know, the PCR remains the standard of reference regarding the diagnostics with very high specificity. However, previous studies have shown that a higher sensitivity for chest CT and for the diagnosis of COVID-19. And another setback of the PCR test is that the test results can take up until 24 hours, while CT results are not immediately available. So this makes it this makes the use of CT as a reliable source, and we can see if that is indeed the case. So the use of imaging, before I start with the use of chest imaging in general, it is really important to know to emphasize that we use chest imaging to establish a diagnosis and guide treatment or management or guide triage. And this comes with a cost, and the costs are risk of radiation, the risk of getting COVID-19 transmission, or the consumption of PPE, and also the cleaning and downtime of radiology rooms in source-constrained environments are really important things to consider. So this in mind, we go to the first slide about the chest imaging. That's slide 7, and it's about the chest X-ray, which is the most available and most used chest imaging in the world. So it is important to know that the chest X-ray is actually insensitive in mild or early COVID-19 infection. And it can be abnormal in a patient with advanced symptoms and in patients who have prolonged disease. And it could also be very useful in a hospitalized patient, assessing disease progressions and alternative diagnosis. So why is the chest X-ray insensitive in mild COVID-19? One of the problems, or you can see on chest on slide 8, the stages of COVID-19, the stages of the CT images, and the changes over time. As you can see in the early stage, the COVID-19 displays ground glass opacities, and the consolidation what is formed later in the progression of the disease. So that is the time frame where you can see the consolidations on X-ray, and you will miss it. You can see it on chest CT, but in the early stages you will miss it on the X-ray. So to give you an example, this is an example of comparison of a chest X-ray with a coronal CT image. And as you can see, the CT image shows ground glass opacities at the lower lobe on the right side. And this is the X-ray of the same patient at the same time. And you'll see that there is no ground glass opacities or consolidations on the right side and on the chest X-ray. So you will miss it on the chest X-ray. That's why in the early stage, the chest X-ray will not be sensitive for COVID-19. So to move on, how can you use the chest X-ray? The chest X-ray, the findings are typical of those of atypical pneumonia, organized pneumonia. So important findings that suggest COVID-19 on a chest X-ray are bilateral or multilobular ground glass opacities or consolidations, and the distribution is most of the time in the lower zones of the lung. So these are some of the characteristics on the chest X-ray which you can use to diagnose COVID-19 or to make a suggestion that this patient may have COVID-19. So these are some of the examples of patients with COVID-19 and their chest X-ray. As you can see, there are some ground glass and consolidations at the lower lobe on the right side and the upper lobe on the left side. Sorry, the lower lobe on the left side and the upper lobe on the right side. So this could be it's multilobular and it's ground glass and consolidation. So this could be a COVID-19 which you can suggest on your chest X-ray. Another example of this ground glass consolidations, multilobular, So you see on panel B and C images of the coronal and axial CT, chest CT of a COVID-19 patient. And you'll see on the A panel the X-ray of the same patients, and you will see that you see on the X-ray also the ground glass copicities and the consolidations bilateral and mostly on the lower lobe. But however, it is really difficult to make this suggestion on an X-ray, and I will show you another X-ray of a COVID-19 patient with typical ground glass opicities on the lower lobes, and you see that on the axial and the coronal chest X-ray images or the CT images. However, you won't see it on the X-ray. Can you see the images?
Would you please just remind on which slide you are? 29, I think.
I'm on slide. I don't know which slide this is.
Vist no.
Yeah, 29.
29. Wist no. Can
you see the images?
Yeah. We can't see the images. Only your slide with blank page.
Oh, that's odd.
Okay. Anyway.
I think something went wrong because we are back on continue to imaging section now.
Yeah. Can you see it now?
Yeah, you are sharing right now. Yeah. Now we see it. Yes. Okay. Please go on.
So that's the story of the chest X-ray. So be very careful in making suggestion of COVID-19, because in the early phases you won't be able to see the ground glass opicities on the X-ray. So moving on to the ultrasound, which is another modality which we can use. So the ultrasound may be useful in the evaluation of critical ill patients on the ICU. You will see irregular thick and pleural lines and super consolidations. And it could be very useful in patients with suspected pulmonary embolism in the presence of hemodynamic compromise, which you will see in the presence of severe right ventricular dysfunction. Again, the ultrasound is not used or cannot be used as a tool to triage or diagnose COVID-19, but you can use it as a tool to evaluate the progression of the disease and evaluate the patients for other diagnoses like pulmonary embolism. So moving on to the chest CT, which is the most important, but the greater sensitivity great sensitivity compared to X-rays or even compared to PCR. And it is really sensitive also in the early parenchymal disease, lung disease, and in progression. And if you acquire it with contrast, interference contrast, you can also see pulmonary embolism. It can be detected, but that depends on the availability of the CT on the location. So there are a lot of guidelines for chest CT. The American College of Radiology has put a guideline, the British Society of Thoracic Imaging, which are both really reluctant in using the chest CT for diagnosing or for triage of COVID-19. But recently, the Fleischmann Society has produced a multinational consensus statement, which is, to my opinion, the most detailed and most comprehensive guideline at this moment. And they have put together multiple specialists. It's a panel of more than specialists from several fields and individuals from several countries like United States, Italy, China, Germany, France, and etc. And they combined represent 9 of the 15 countries with the highest number of COVID-19 cases. And they present us, you'll see on slide 18, with different scenarios, with different clinical scenarios, which chest CT can be used. And the bottom of line or the key points in that guidelines is that the imaging is not indicated in patients with suspected COVID-19 and mild clinical features unless they are at risk for disease progression. Then you can use the chest CT as a baseline to see if the disease is progressing. The imaging is indicated in patients with COVID-19 and worsening status. So again, to see the progression. And in the source constraint environment, imaging is even indicated in a triage of this patient to distinguish the patients or separate the patients with high suspected COVID-19 and the less suspected COVID-19 patients. And these are in patients with moderate or severe clinical features and high probability for the disease. So moving on, what are the chest CT findings which are more or less typical for COVID-19? These are ground glass opacities, like mentioned before, with or without consolidations. And the lung regions that are mostly affected are visceral surface and with multifocal bilateral distribution, and mostly on the lower lobes. Sometimes there is crazy paving is seen, and another sign could be the reversed hollow sign and thickness of the vessels, and abnormalities could be typical. This thickening of vessel could be also typical for COVID-19. Again, this is a COVID-19 patient with typical findings, as you can see. Ground glass opacities near the visceral surface in the lower lobes, but also in the upper lobes. Multifocal, you see there is a crazy paving in here with thickening of intra lower rooms. Another, you also see the consolidation in the lower lobe. So these are all could be signs of COVID-19. Okay. So I cannot move the slide.
I think you have to close the panel at the left side with your pencil.
Panel of the left.
Yeah, and now click and proceed.
Okay, thank you. So these are some typical and atypical findings in COVID-19. Typical findings are multifocal ground glass opacities, peripheral and basal distribution, and vascular thickening could be seen in crazy paving, as mentioned before. Also, consolidations could be seen. And atypical findings would be more atypical distribution, so more in the upper lobes than in the lower lobes. Also, enlarged lymph nodes are not seen that often. And other more very atypical findings would be cavitation, tree in bud, nodular patterns, and mass. So that's really important to keep in mind. Again, to be able to communicate these findings with the clinics, it's really important to have a system or to have a way in which you can communicate these findings in in a standardized way. So in the Netherlands, we have created in our own hospital the CORAS classification, which is it's a system of communicating these findings to the clinic. So it's developed by the Dutch Radiology Society, and the classifications gives a level of suspicion of COVID-19. It's graded from very low to very high. It improves the communication with the referring physicians, and also gives you a sense, because you cannot, and even on the chest CT, the diagnosis is really difficult. You have to give some sense of a gradation if the CT diagnosis of lob gradation of ground glass opacity, also other viral diseases. So that's why this system is developed. So the system is developed, and there are 6 classifications. CORAS 0 is actually which is not in difficulties is not is to interpret. The CORAS 1 gives you it's a CT which has normal or non-infectious view or image. So the COVID-19 involvement is very low. CORAS 2 classifications could be seen in the typical or other infection of COVID-19, like if you see tree and butt image with tree and butt, that would be CORAS 2. CORAS 3 is actually unsure. So the features that you will see on CORAS 3 could be COVID-19, but it could be other diseases of viral diseases of the pulmonary of the lung. So that's unsure diagnosis. CORAS 4 and 5 are actually very typical for COVID-19 and suspicious for COVID-19. So and CORAS 6 is actually proven COVID-19 with PCR positive COVID-19. And I will go in more details of this in this classification. So as I said, CORAS 0, incomplete lung CT, probably with because of technical insufficiencies or technical problems. So this is a CT which you cannot read, or you cannot say you cannot use it as a tool. CORAS 1, so the level of suspicion is very low, and you can see this in normal chest CTs or findings which are not comparable with infectious etiologies. Diagnosis could be nodal, tumor, or other intestinal edema, so not suspicious for COVID-19. This is a CT of a patient with CORAS 1. You can see there are no ground glass opacities, there are no consolidations. So this is a typical normal CT, and you would classify this one as a CORAS 1. So CORAS 2 has a level of suspicion which is low. Again, the findings could be typical for infectious diseases. However, it's not compatible with COVID-19 because the typical features of COVID-19 are just missing. And this is a CT of a patient with CORAS 2 classification. As you can see, there are some small ground glass opacities and some wall thickening of the bronchus. So this would be COVID, or this would be classified as CORAS 2. And as we move, another example of chest CT with CORAS 2 with consolidations in the upper lobe, in the base of the upper lobe on the left side, which will be seen as a consolidation in the will be diagnosed as a lobar pneumonia. And again, you don't see consolidations or ground glass opicities which are multifocal distributed. So this would be again a CORAS 2. So moving on to CORAS 3, level of suspicion is unsure. So there is a lot of overlap with other pathologies. You cannot say for sure if it's CORAS COVID-19 or not. And the features found can also be found in other viral pneumonias. And you can see this. This is one of examples of CORAS 3 classification. As you can see, you can see in the arrow points to a single focus of ground glass opacity. So this could be a COVID-19 again, but you don't see a multifocal distribution. So that's why you cannot for sure say this is a COVID-19. So that's why it's unsure. Again, another bilateral ground glass opicities, another example with interlobular septal thickening and pleural vision. And again, this is a patient with cardiac problem, with cardiac decompensation. So the ground glass opicities could be COVID-19, but there's also decompensated heart failure here. So this would also will be classified as a CORAS 3. Moving on to CORAS 4, which is a very high level of, or a high level of suspicion. The findings are typical for pulmonary involvement of COVID-19, but there are also some features of the other viral pneumonia. And the findings could be similar to the to CORAS 5, but some features, some typical features are missing, like no contact with the visceral pleura, or just located strictly on a unilateral basis. And so these chest CTs would be characterized as a COVID or CORAS 4. And you can see here as a CT classified as CORAS 4. As you can see, there are ground glass opicities on the right side. However, on the left side, you don't see ground glass opicities. So again, if on the right side the ground glass opicities was also, on the left side was also seen, then this would be a CORAS 5. But because it's not seen, it's a CORAS 4. Moving on to CORAS 5, which has a very high level of suspicion. Findings are typical for the involvement of COVID-19, and findings should be new or increased. And to give you overview of the typical features of COVID-19 involvement. So these are ground glass opicities with or without consolidations in lung regions close to the visceral pleura, and including the multifocal and bilateral distributions. And other confirmatory patterns could be crazy paving, thickening of vessels, what I mentioned before, and the patterns could be compatible with the organized pneumonia. So this is a chest CT of a patient with bilateral ground glass opicities near the visceral pleura, with distribution in the basal or in the basis of the lower lobes. So this would be a typical CORAS 5 classification. Another example of a patient with ground glass opicities with multifocal distribution, mostly in the lower lobes, and consolidation also in the lower lobes. So this is also an example of a CORAS 5 classification. Again, another example of ground glass opicities with multifocal distribution, mostly in the lower lobes and also in the base of the upper lobes. This would also classify as a CORAS 5. And again, if you see these features only on the one side of the lung down, then you would classify it as a CORAS 4, another CORAS 5. Again, CORAS 5 classification with multifocal bilateral consolidation and ground glass opicities with thickening of vessels and some subpleural sparing, which is typical for CORAS 5, typical for COVID-19, and this will be classified as CORAS 5. So in the, as I mentioned before, the paper of this has been published in radiology, and in this paper, you can see that the false positives for CORAS 5 classification is very low, is 0.3%. So patient with CORAS 5 classification has a very high suspicion of having COVID-19. And if you look at the other side, so the CORAS 1 classification, the false negative there is just 5%. So again, the CORAS 1 patients have very a low suspicion of COVID-19, whereas CORAS 9, CORAS 5 classification has very high suspicion of COVID-19. And CORAS 6, of course, are patients with positive PCR and any pulmonary findings. So these are patients who are tested positively. So take-home messages. It's really important to acknowledge that the chest CT or chest XR is insensitive for mild and early COVID-19 infection, and it may be abnormal in patients with advanced symptoms. Then you can use it to follow as a follow-up tool for the patients with COVID-19. Ultrasound may be useful in the evaluation of the critical patients and in diagnosing suspected pulmonary embolism in patients with compromised on the ICU. And chest CT imaging, it's important to know or to emphasize that the ground glass opicities, with or without consolidations, are the hallmark of most seen in COVID-19, and it is close to the visceral pleura surface, including the viscera and multifocal lateral distribution, with sometimes crazy paving and thickening of vessels. So that's the take-home message that we want to give you regarding the chest imaging. If there are any questions for me or the other members of the panel, then we are glad to take it. Thank you, and I'm sorry for the technical difficulties.
Thank you very much for the great presentation. Excellent. تشکر بسیار زیاد متخصص ابسالا و متخصص هاشمی. واقعا خیلی لکچر عالی بود از هر دو بخش. دوستایی که سوال دارن میتونن که آمادگی سوال خود بگیرن. فقط ما وعده کرده بودیم به دکتر صاحب فرید رفی، اونا یک سوال در ابتدا داشتن از دکتر صاحب هاشمی. اگر اشتباه نکرده باشم سوالشان تکرار میکنم. هدف اونا این بود که آیا گروپ خون یعنی کدام در بخش ارتباط تشخیص و یا خود امراض کووید کدام رولی داره یا نه. هدف اونا این بود که گروپ خون A شاید که بهتر باشه و مریضاش زیادتر پروبلم زیادتر کووید دچار نشن. یا در این باره اگر کدام معلوماتی باشه دکتر صاحب هاشمی.
بله، تشکر از سوال بسیار عالی. من کدام جای چیزی در این مورد خواندم که گروپ خون A ممکن است که بیشتر سویر دیزیز داشته باشن و گروپ خون O کمتر، ولی اطلاعات در این مورد بسیار اندک است و نمیتونیم به شکل یک دیاگنوستیک تست یا پروگنوستیک تست ببینیم به نظر من.
تشکر. دکتر صاحب اجمل زاید شما سوال داشتین؟ هستن اونا؟ من خاطر لیست دوستا رو نمیتونم دیدم.
تشکر هاشمی صاحب. کوشنی سے بزرگوار تا سوال نداشتم، فقط یک پیشنهاد داشتم. باز اگر داخل گفتین حالا گفتین باز میشه بگویم.
بفرمایین، خدمت شماست.
کوشنی سے بسیار تشکر. من برنامه رو بسیار تقدیر میکنم. وقت خوب برنامه بسیار آموزنده بسیار عالی از وقت بسیار تشکر میکنم از زحمات شما و هستین محترم که وقت وقت میگذارن و تشریح میکنن و ما را بسیار آگاه میسازن از مسائل بسیار جدی و بسیار مهم. فقط یک پیشنهاد داشتم که اگر امکان داشته باشه یک پروگرام ترنینگ 2 روزه یا 3 روزه بسازین که در آخرش یک سرتیفیکیت هم داشته باشه وقتی کسایی که فرصت میکنن تا باشد یک تشویق هم از طرف شما ما شویم و از طرف ما شما یک مارکتینگ با شما هم چی شود و به ما هم کردیت شود چون ما بسیار چیزا را مختیم و میخواد یک سند به ما شود یا باشه یک افتخار ما بخشیم که بتونیم از استفاده بکنیم.
تشکر، خیلی نظر عالی است. در این باره فکر میکنیم چرا که بعد از کووید ما پلان داریم که پروگرام های دیگه هم به تعقیب از این داشته باشیم. برای ما و نمود شده که دوستا و همکارای داخل کشور میتونن که ما از اونا چیزی یاد بگیریم و بالقبل چیزی که ما یاد داشته ما باشه میتونیم با اونا شریک بسازیم. خیلی نظر عالی است، میتونه که باعث تشویق اشتراک دوستا شد و حتما در این باره ما غور بررسی و بحث میکنیم و شما را در جریان میمانیم. نظر عالی است.
تشکر بسیار، تشکر کسانی سے بخیر.
خواهش میکنم. دکتر صاحب رفی، مایک شما چالان است، بفرمایید. سوال داشتن، شما میتونید خودتان سوالتان از دکتر صاحب سوال بکنید؟ خب دکتر صاحب سوال از اونها این بود که تشخیص تفریقی میان دریافت‌های رادیولوژیک کووید 19 و عدم کفایت قلب. دکتر صاحب باشی میتونین که سوال از اینا رو امکان داره یا من نتونستم صحیح درک کرده سوالشانه؟
دیفرنشیال دیاگنوستس هست با هارت فیلر، کنجستیو هارت فیلر و فایندینگز از رادیولوژیک فایندینگز با کووید 19.
اوکی. بخش کاری متخصص سلام هست، بخش رادیو کاردیو دیاگنوستیک.
I didn't catch the question, sorry.
Could you please repeat the question, Dr. Saab Masiullah, but in English?
Of course. He has asked that what's differential how can we differentiate or differential diagnosis between radiologic findings of COVID-19 and heart failure, acute heart failure, that are very similar to each other. And could you please shed some light on differential diagnosis of these two conditions?
Yeah, of course. Well, it's really difficult so I want to emphasize that it's really difficult to distinguish COVID-19 with a lot of diseases. There's a lot of overlap with especially other viral diseases, but also with heart failure. So the decompensated heart failure. But the most important thing is on a chest CT or an X-ray of heart failure, you will see the thickening of the interlobular septi, which is not seen in COVID-19. So that's really important. The edema that starts with acute heart failure is not seen in COVID-19. So that's a really important sign to look for if you want to make that distinguish between heart failure and COVID-19. You won't see in COVID-19, as I mentioned, a thickening of interlobular septi. And if there is thickening of interlobular septi, you will see thickening of intralobular septi, which is then seen as crazy paving, and not just the interlobular septi, which is seen in acute heart failure. So that would be a way to distinguish these two. But again, I understand the question. It's really difficult to distinguish a lot of diseases from COVID-19.
Thank you.
Can I have another remarks on that? As Dr. Salah mentioned, of course, the crazy paving and the thickening of the interlobular septa, but also you can look at the distribution of the ground glass opacification. In COVID-19, mostly the distribution is more peripherally, so more in the subpleural area. And usually, but it's not always the case in decompensation. So in heart failure, you can see ground glass opacifications, which is signs of pulmonary edema more centrally, so more around the peribronchosvascular area. So that could help as well.
Thank you very much. دوستای هستن اگه سوال نداشته باشن من یک سوال عمومی از همکارای ما دارم. خب من سوالم این است، هم متوجه متخصص باشمی و هم از مرسل جان و خیبر جان است. من قراری که دیدم فکر کنم که در حالت سیتی اسکن خیلی مهمتر نسبت به اکسری است، مگر نظر به امکاناتی که در افغانستان است فکر کنم زیادتر اکسری به دسترس است، ولی سیتی اسکن خیلی قرار معلومات ما امکانات کم است که دسترس باشه. آیا ما میتونیم همکارای ما را با وصف کمبود امکانات دیاگنوستیکی که دارن از نگاه بخصوص تشخیص خون یا تشخیص PCR و در پهلوی از نگاه اکسری بدون از اینکه سیتی اسکن در کار باشه، میتونید در این باره کمکی معلومات زیادتر بدین؟
Dr. Sepsala?
Oh yeah, of course. Look, the X-ray can be used, as I mentioned before. However, it should be it's insensitive in the early stages. So if the patient is referred by a GP to the hospital or whoever, and he or she has symptoms for just 1 week or 4 days, and so that's the false negatives will be really high. So that's one thing to remember. However, if you have patients with advanced symptoms who has a prolonged symptomology, you can use the chest X-ray and see if you see these patterns of consolidations, because consolidations are formed later in the disease progression. And in the early phases, you see ground glass opacities. And ground glass opacities are really difficult to see on an X-ray. It could be seen, but it's really difficult to see in the early stage. So if you have a patient with a late stage, you may find these ground glass opacities or consolidations, which has the same distribution as CT, multilobar, peripheral, in the lower lobes. And based on that, you can say, okay, this could be COVID-19 patient. So that can be used. But again, it's because it's difficult on an X-ray to diagnose the disease on an early stage. So that's the difficulty. But yeah, I can understand the question. It is indeed difficult, maybe in source constrained environments to get a CT. So if not, then use the chest X-ray, but be careful with your with the diagnosis, or be careful with the interpretation of the imaging.
Thank you.
So I don't know if Morsala has anything to add to this.
No, not really. I think everything you mentioned is true. So it is really difficult, and I was myself. I was also wondering how many hospitals in Afghanistan have access to CT imaging. So that's why we did mention also the chest X-ray results. But I have to say, as Dr. Salah mentioned, the false negative numbers are really high. So you have to take that into account. But I think if you have the clinical information of the patients and you have the chest X-ray, you can get far.
Thank you. هستن از همکارای در افغانستان بفرمایید مسئول جان.
Okay, my question is from Dr. Salah. As you mentioned before, that chest X-ray cannot help us to find any ground glass opacity in the early stage. But if we take two chest X-rays, one from posterior anterior view and another from lateral view, does it help to detect some abnormalities in chest X-ray, or does it help us to diagnose, or does it give us a clue to diagnose COVID-19 from chest X-ray?
Thank you for your question. And no, I'm sorry to say that, but you won't see the granules opacities on the site. So a coronal view or a sagittal view won't change the matter. It remains difficult to see these granules opacities in the early stage. Yeah, getting another view on an X-ray, so from a sagittal point, won't help you, but it can help you to to exclude other diagnoses. So that could be helpful, but it won't help you for diagnosing COVID-19 in the early stage.
Thank you. Masiullah John, as we know, we have shared with you and with radiologists in training in Afghanistan about the DELF imaging techniques. Could you enlighten us what was his reaction on that, and do you think that DELF imaging techniques would be an adding value based on the limited resources what we have in Afghanistan?
Thank you. I talked about DELF application with Dr. Sabiratullah Midi. I think he was here with us, but got some technical problem and so disconnected with us. I am talking with him once again, and let's see what's his opinion, because he's a radiologist and he can say us about whether it's helpful for us or not. So I will talk again with him.
Thank you very much. Okay, then we could also help you with DELF imaging as well. So I understand, as Dr. Salah and Dr. Samim mentioned, the limited resources of Afghanistan. Is there someone from COVID-19 ward here right now with us to just give us an impression of the difficulties what they actually face on daily basis? Otherwise, you have the mic, Masiullah. I know you are also well-known with it.
I think we had sent him invitation link, but we have not any one of them right now.
Okay. Then if there's no another questions, then we will stop here. We have only time for 1 or 2 questions. Okay. با فکر من که معلوماتی که آماده شده بود و طور عالی بوده و جامع بوده که فعلا همکارا دیگه سوال ندارن. تشکر که با ما بودید و انشالله هفته بعدی هم پروگرام هست و کسایی که میخواین شامل پروگرام شوند میتونن دوباره باز با دکتر صاحب مسیح الله هاشمی ارتباط بگیرن و دعوتنامه برشان روان میشه و هفته آینده در بخش تداوی کرونا صحبت میشه و ما دو همکار و خود که در خط اول و در بخش اول تداوی کرونا اونام را شرکت داشتن، اونا با ما هستن. تشکر از همه همکارای افغانستان. افطار خوش به همه شما. ما همراه همکارای آلان فقط میمونیم، یک ایوالویشن میکنیم.
دکتر صاحب کوشتنی یک کلیگ همکارا هستن، یک معلومات میدین که اگه هفته نو مثلا اگه در برنامه زوم بریم که پیش از پیش
بله
ترتیبات بشه.
بعد از این قرار معلومات ما در ابتدام وبکس انتخاب به خاطری کردیم که ما فکر کردیم که ارتباط اینترنتی بهتر با افغانستان شاید داشته باشه، ولی سر از هفته آینده از طریق وبکس نه و از طریق زوم به معلومات جدیدی که دکتر صاحب مسیح الله هاشمی به ما دادن، امکانات اینترنتی با زوم بهترتر است و از طریق زوم با شما داخل تماس میشیم. دکتر صاحب نبیل تشریف دارن؟ من نمیتونم دیده، اونا یک سوال داشتن ولی فعلا دیده نمیتونم که اونا هستن یا نه. دکتر صاحب جاید نبیل نیستن فکر کنم.
پیش از او نه نیست.
خب پیش نظر میتن کسایی هستن که زوم میگن پروگرام در برنامه زوم اینجا کمتر کار میده چون دیگر پروگرام ها رو نتوانستیم تعقیب کنیم. هدف تانی است دکتر صاحب افضل که فعلا بهتر است نسبت به یعنی ما زوم استفاده نکنیم. خب در این باره باز فکر میکنیم ما همراه همکارا و یک بار دوبار پیش از اینکه پروگرام زوم استفاده کنیم ما با هم سعی میکنیم و افغانستان چک میکنیم. مسئولا جان شما همراه ما باشین. دیگر دوستا شبتون خوش و افطار خوب داشته باشین. خدا حافظ شما. Je kan mensen die er zijn, kan je geforceerd afscheid nemen.